Thank you for giving me the opportunity to talk today. There's so many ways in which health and wealth are inextricably intertwined. And I'll be talking mostly about the health applications, but one aspect of this is that NIH has two centers on behavioral economics and health in the US. One is a center run by our colleague David Leibson that is focused on financial savings behavior and the links that has to health. And then I lead our center that's focused on health and health behavior. But here's some data that really highlights a lot of these links, and I think they're really bi-directional. It's important to think through. So this was a study published in the Journal of the American Medical Association by the Stanford economist Raj Shetty very recently. And it really highlights within the US how strongly life expectancy and income are intertwined. So what the graph shows is how life expectancy varies based on where you are in the income distribution. If you're a man, there's a 15-year difference in your life expectancy depending on whether you're in the first percentile or the 99th percentile of income. If you're a woman, there's a 10-year difference. And I think it's important to think through what this means in terms of the bidirectional aspects to this. Obviously, people who are wealthy have a lot more opportunities to focus on their future health. Day-to-day life is much less of a struggle. On the other hand, unless you're healthy, you obviously can't work and can't accumulate wealth. And so both are important to think about, both as people get older and as they're in middle age, and we try to prevent premature aging in many ways. So as we think about this as behavioral economists, there's a number of important elements to think about as we design programs. And I'm just going to give you a small snapshot of a few of these. We have a paper we're working on for the World Economic Forum Global Advisory Council on Behavior that I'm part of that more comprehensively maps this out, and we'll try to have that ready soon and make it available to public and private organizations to hopefully help navigate. But here's a snapshot of a few of these important decision errors. One is that people tend to be very focused on the present. And this is a big challenge both with health and savings behavior because people are always thinking about the immediate costs and benefits of their action and much less about the future. We also know that there are very pervasive mental accounting effects. People focus much more on what they can see. So, for example, health plans will often give people rewards that are tied to discounts on their health insurance premiums. Those discounts come in the form of electronic deposits in the bank that are added to their paychecks, and that makes them fairly invisible. You can hide $100 pretty easily by doing that. If you hand somebody a $100 check or gift card, obviously that's going to be much more apparent. We also know that people are susceptible to choice overload. And the clear implication there is we need to think about giving people a smaller number of choices or perhaps guiding them a bit in wading through all the many choices. Often organizations don't recognize that if you give people a long list of different choices, they're going to focus on what's at the top of the list. They're often going to focus on whether, if there's a default, what the default is. Those are often seen as an implicit recommendation. And we should be very thoughtful in considering what those defaults should be. There's also issues of people being very loss averse. People have a disutility of losses that's much stronger than their utility of gains. This can be used selectively to try to encourage ongoing engagement. And people also have a very strong status quo bias. So even if there are new choices that become available, let's say I'm given a choice of health plans each year by my employer, there might be much better alternatives than what I'm currently using, but overwhelmingly people will pick what they had last year because that is the path of least resistance, and it's far easier than wading through all the information on the risks, the benefits, the costs of the new alternatives. This is one of the more famous slides, let's say, in behavioral economics, which really just highlights from a descriptive standpoint the power of opt-in versus opt-out defaults. The countries on the left in yellow are countries where you have to opt in to be listed on the organ donor registry list. The countries in the right in gray are countries where you're presumed to be an organ donor unless you explicitly say you don't want to be. And you can see there's a dramatic difference here in the percentages. There are very few interventions that we could imagine that would have this kind of effect size. Very important to think about as you design programs. Does it need to be an opt-in? Many health programs are set up as opt-in programs. perhaps could be opt-out programs would have very different implications for enrollment rates. But thinking about aging in other contexts, here's another context where it's perhaps a bit more challenging, thinking about what the defaults might be. This was a study that was led by my colleague Scott Halpern, who's a critical care physician at Penn. And he, like many others, had made the observation that at the end of life, for patients with terminal diagnoses, often in the US, we're far too aggressive in treating disease. In essence, the default is we do everything for everybody, perhaps even beyond the point where it actually makes sense. And what Scott wanted to test was whether changing the defaults for patients with very defined clinical conditions where you could argue quite reasonably that less aggressive care might be better, whether changing those defaults affected what people chose, given that this was a very high stakes decision. And he randomized people to either a comfort-oriented plan of care on their advance directive. This is all in pencil. People were told you could just cross this out and pick whatever you want. The standard advance, do everything you can for me as long as you can, or an approach where basically the clinician and the patient's family would decide later. So what the team found was very interesting. People randomized the comfort-oriented plan of care actually chose to stick with that 77% of the time. People randomized to the aggressive, do everything you can for me plan of care overrode that default and picked a comfort-oriented plan of care 43% of the time. People who were in the middle with the standard advance directive chose a comfort-oriented plan of care 61% of the time, suggesting that most people in a neutral frame actually preferred the comfort-oriented plan of care. Now you might wonder, do people really understand what these choices meant? You know, a lot of these discussions, if they seem theoretical, you always worry or wonder, do people really understand what's at stake? And what was examined was really the sense of, do people understand what's the likelihood I'll get a feeding tube, dialysis, cardiopulmonary resuscitation, mechanical ventilation, and this followed very closely. People did seem to understand what this meant. And I think what this really highlights is that even in these high stakes decisions, people often will respond to these defaults, particularly if someone they trust is making this and they see it as an implicit recommendation. Now, often in health decisions, we can't just default people into opt-out defaults. And we could debate at length, is that a good idea to do in this particular context? But another context where this comes up frequently is medication adherence. We have a lot of patients who are on a lot of medications, and it's very hard if you're on 10 or 15 medications to remember when all of them are due, when all the refills are due, is a fairly complex organizational task. CVS had developed a plan that was an automatic refill program for people on a lot of medicines, and they thought it was self-evident that everyone would want to sign up for this, but it was an opt-in program, and like many opt-in programs, they had a sign-up rate of about 15%. They asked us how to increase the rate. The first obvious question was, could this be an opt-out type program? And they said, no, every time we have to send out these prescriptions, we have to charge people's credit cards. People will be very upset if they haven't authorized each of those charges. So what we did is we used an approach we call enhanced active choice. And you can think about this as a fairly gentle nudge. On the bottom left, if you prefer to refill your prescriptions by yourself each time, press 1. If you'd prefer for us to do it for you automatically, press 2. This could have been a much stronger nudge than we used, but it roughly doubled the rate at which people signed up for the program. CVS now uses this as an on-ramp for many of their programs because it has the desirable property that is something people actually chose as opposed to something they were defaulted into. Now, another context where we might think about health and healthy food choices was some recent work we did with Discovery Vitality. And in South Africa, they have a very generous program to encourage people to consume healthy food. It's actually a 25% discount on healthy food. You would have thought that everybody would sign up for this because why wouldn't I want a 25% discount on healthy food? But like in many other arenas, it's very hard sometimes to get the patients you most want to get engaged in a program. So we decided to do a test of various ways of messaging participants. And you can think about this as the kind of approach which any organization could do with their efforts to communicate to members and make known to them the benefits of some of the different types of interventions they could participate in for free. So the control arm got no message. There's also a diabetes-specific message. This was all targeted to diabetics in whom we thought there was particular benefits to signing up for a healthy food program. One message had a provider recommendation frame, another had a recommendation from a fellow member, and then the final used an enhanced active choice frame similar to what I just described. What you see in the graph on the bottom here is that all of these messages were much more effective than no messaging at all. And I think that's one important message to get, no pun intended, one important message to get across, that a lot of times you can actually get a pretty good lift from a low-cost intervention. But this enhanced active choice approach actually did outperform all the others, including the member-specific and the provider recommendation. We used language, yes, I'd want to activate the healthy food benefit, get up to 25% cash back, versus no, I'd prefer not to activate, continue paying full price for my healthy food purchases. So there's no subtlety there. The idea is we just want everyone to understand, you're free to say no if you want to. You're free to say yes if you want to. There's no requirement here to do either when we think about the libertarian paternalistic aspects to this. But we want it to be clear to you what the choice is. And in people's busy lives, it's very easy to miss what are the salient features of the program. I think there are a lot of opportunities to use approaches like this and just make it more apparent to people what am I actually choosing between. Now, another big area in terms of thinking about premature aging in the US is that employers are now able to provide very large incentives towards healthy behavior. As part of the Affordable Care Act, employers can use 30 to 50% of premiums on penalties or rewards tied to outcome-based incentives. And these can be for blood pressure, cholesterol, body mass index, or smoking. So potentially huge amount of money. But what we've seen is that many health plans, many employers just do this by adjusting people's premiums. And there's a lot of evidence from other types of work that because of the mental accounting issues, premium adjustment is a fairly ineffective way to adjust people's behavior, particularly when you think about it dollar for dollar. A lot of the testing we've been doing is trying to build data on how to do this more effectively. This was a study we did that CDC funded among employees at GE. We provided a $750 incentive outside of the premium structure, roughly tripled smoking cessation rates. GE now uses an approach based on this for all its employees in the US. And then we followed it up more recently with a National Cancer Institute funded study done among CVS employees where we tested group rewards versus individual rewards. That had very little impact. We also gave people the opportunity to put some of their own money at risk, which we matched 4-to-1. That worked very well for people who did it, but only about 14% of people were willing to do it. So in essence, we found that the standard reward worked better. What we're now testing among CVS employees is an approach where a very small amount of money gets put down by the CVS employee, $50. This is now matched 14-to-1 by CVS, hence the name 700 Good Reasons to Quit. The idea is to really engender loss aversion among participants where it's very attractive to participate because now you're getting a 14-to-1 match. So no results yet, but we'll see how that goes. So in conclusion, I think there's a lot of potential for behavioral insights to be really helpful in thinking about wealth. Nudges tend to be very appealing because they can be seen as gently pushing people in self-beneficial directions, but if properly constructed, they're not overly heavy-handed. People can easily opt out and choose to do something else if they have strong preferences. We can think about using defaults when the interest of the consumer or the patient and the choice architect aligns. Sometimes this is a little bit tricky. So for example, with a lot of the early retirement savings work, when the default was picked at 3%, people picked 3%, even though it was actually optimal for the employees to pick 6%. So we have to be very careful in thinking about where we nudge people. Obviously, the interest of the employer, the employee, in that case, may not perfectly align. We can also think about enhanced active choice in settings where ongoing engagement is needed, and incentives that help to encourage action now to encourage future well-being in settings where that might make sense. Thank you very much.